I'm going to invite our next speaker, Dr. Stan Hamstra, the Vice President of Milestone Research and Evaluation from the Accreditation Council for Graduate Medical Education.
Thanks, Joan. Morning, everyone. You have to forgive me if I'm a little sleep deprived. I haven't been sleeping that well, but I love flying from Chicago to New York because you sit beside the most interesting people. And so I had 2.5 hours of a guy talking to me about assessment-backed securities and complex derivatives. And I still couldn't get to sleep. So he failed. I'm going to talk about how we track milestones across, or the potential for tracking milestones across the continuum. This is essentially a talk about competencies. I've been studying competencies and assessment of competencies for over 20 years now. I'm a PhD scientist, so I'm not an MD, but I've been studying you for 20 years. I just have to say, I think there's a lot of principles that we can share. I'm basing this talk partly on what we did last year, so it's a little bit of it will be repetitive from last year. I hope that's okay with those of you who are here, because I'm going to emphasize what I think are some really key fundamental points in this whole competency-based revolution that we're in. And really what I want to say is, how can we help? How can I help? How can we help at the ACGME with Milestones in competency-based medical education to help you realize the vision of looking across the continuum? So I'll just do 3 things. I'll recap briefly what we did last year. I will talk about remaining challenges, and there's quite a few of them, so I'm only going to touch on 1 or 2. And then I'll talk about what I think are some potential solutions to some of those challenges. So one thing we did over the last 1.5 years, Eric Holmboe and Laura Edgar and I, was we went out on the road. And according to Laura, we gave over 220 talks, Eric, between the 3 of us. I think I only did 60, so, I was the slacker. But we called it our listening tour. And some of the things that came out were very positive. You can think of this as kind of a qualitative summary of the impact of milestones across the GME community. So people are saying to us that the quantity and the quality of the feedback to the residents has improved since milestones were developed and made a requirement in December of 2013 for certain specialties. They talked about the CCCs, and the clinical competency committees, and how this has improved and focused them in their deliberations about the residents, in particular about identifying residents in difficulty. So that is key to competency-based medical education, is getting some kind of objective evidence to support your gut feeling that one of your residents isn't doing too well in a particular area. So this is actually a really nice signal to get from the community. And we do actually now have a few qualitative studies underway to document this systematically and put it out there in the literature. It's also helped them with curricular improvements, faculty development. It focuses them on those competencies and milestones. Now you may say, well, the milestones aren't comprehensive enough and they don't cover everything that you need to learn in a specialty. Fair enough. But at least this helps them provide some focus for that. It brings in, this is one of my favorite things about the milestones. It brings this, and the next accreditation system, it brings this continuous quality improvement lens into education. And the reason I like it so much is because you all, as healthcare providers, understand CQI. You understand QI metrics, you understand methods. You understand sensitivity and specificity, the complex processes involved in decision-making, the uncertainty involved with patient diagnosis and treatment. So why can't we use some of those same principles to think about education and making the right decisions about our learners? So I think that's a real nice way to resonate with the educators in your institution. And also, this happens to build in a system of documentation, if you think about it, that you can go back and you have a paper trail from day one when the resident entered your program, you have a system of documentation. Challenges, obviously some simple things that aren't so simple. Logistics and data entry are constantly coming up. This is a big one, and this is what I'll get into a little bit more detail throughout the remainder of my talk. The assessment processes themselves are vague, non-standardized, and have questionable validity. So we'll get into that. And then a separate process is how do you map the assessments onto a milestone judgment? Is there a best way of doing that? Is there a way of doing that? People are all over the map here, and we need some guidance. Our views always win. I don't think I have to tell you about that. And the assessment tools, again, I'll get into that. They have to be feasible. I think one of the things that people recognize in the field is that we have a suite of assessment tools now, but not all of them are so great. How do you assess professionalism? What about communication? These are things that we're not social scientists, you know. I mean, I might be. You're not. So how do you do that? You weren't trained, right, in these things. You're trained in medical knowledge and patient care, and now you're being asked to think about these social psychology type things and assess them and teach them. So we need these better assessment tools. They have to make sense to the core faculty in your institutions. So let me just recap what I presented last year, because I'm just so excited by this data and the potential for Milestones to make a difference for society, honestly. These data that I'm about to show you are the most exciting data that I've ever seen in my entire career. And so now I have to deliver. So it all boils down to this generic Milestones template and level 4. So what does a graduating resident look like? That is the question. At the end of training, the program director has to summarize the milestones for the resident and say, are they ready for unsupervised practice or not? That's a high stakes decision. So I showed you this last year. This is neurological surgery, real data across all 140 or so residency training programs. And what it shows here, I don't know if I have a pointer. I do on here. I can point with this somehow. Oh, up there. Can I? No, I'm not figuring it out. Anyway, is it one of these? Oh, up there. Oh, okay, thanks. Thank you so much. Okay, that's good competence. So what we have here is it's a little bit complex at first, but once you get the hang of it, I'm going to show you a couple slides that look exactly like this, just with different data. So this is a 7-year training program. It's neurological surgery, and this is the level 4 attainment rate nationally across the different patient care subcompetencies in neurosurgery. So you would expect that 0% of PGY1s at the end of their first year of training achieve level 4, remember that's the graduation target, by the end of their first year. And that's basically borne out here. 0% of them are at the level expected of a graduating resident. What's interesting is that not 100% are at level 4 by the end of year 7. That's CQI in action. That is fascinating to me, because what that's telling us is that they are graduating these residents, and yet the milestones don't actually provide evidence consistent with that, if you think about it, that's fascinating. It means that they're reporting honestly about their residents and the milestones as they're going through the system. That, to me, as a psychometric type guy, this is validity. I mean, they're doing that for a reason. I mean, they have every incentive to kind of put these all at 4, and they're not doing it. And so we've ordered them in the order that they appear here at the final, at year 7. And there's a lump here that appear above 90%, traumatic brain injury, spinal neurosurgery, brain tumor, critical care. But then there's these couple at the bottom, around 70%, epilepsy, movement disorders, and pain and peripheral nerves. And when I showed this to the RC for neurosurgery and the Senior Society for Neurosurgery, I said, does this data make sense? And they said, yeah, it actually does. And I said, okay, why? Like, what, how does that make sense? And they said, well, because these are things that every neurosurgeon has to know, And we can think of some cases where they don't quite get it perfectly, and, but they can compensate, or they'll be supervised, and we're okay graduating them. But these things, maybe they're not so critical for every neurosurgeon to know about. And I said, okay, so either we reweight the milestones for your specialty and say, well, these things aren't quite as important as those things, or if you tell us that these things are all equally important, then we can help you look at these programs where these residents are struggling on those 2 subcompetencies and maybe give you some advice about rotating them around to different hospitals in your region, doing simulation, that kind of thing. This is the power of the data. This is what I'm saying. This is by far the most exciting slide that I've ever seen in my entire data-laced career. Now, you don't want to change a whole specialty based on one data set, right? So, being the conservative person I am and skeptical scientist, we looked at the 2015 data. And there it is. And you can see that not much has changed. In fact, I think these 2 flipped and everything else is in the same order. So that gave me hope. But being super skeptical, I thought, what about the 2016 data? And you can see that the pattern holds. So something is happening in that community that's stable. There's a culture around reporting milestones that is meaningful, and we can use it to make a difference within that specialty. Okay, so I could stop there literally, but this is what I presented last year, so I owe you something else. The remaining challenges. One of the things that just keeps coming up is how do we get faculty to use these assessment tools and provide us with valid assessment data and all that other stuff that I won't get into actually, but we could create a list of about 10 things easily. This is from Jason Frank. This is from one of his, I stole this from one of his presentations. There's this weak assessment culture. There's this failure to fail. People don't like putting people at the bottom end of a scale. This is social psychology 101. Assessment faculty don't kind of buy into it. How do we improve that? And I think also one of the things that is particularly relevant to this session today is what I call the projection problem, and that is everyone wants to jump to using GME milestones data as an outcome, right? So if you're thinking about UME and what we're getting in residency, you want the program directors to tell you, like, these residents did fine on these milestones, and therefore it validates what we're doing in UME. Well, not so fast, because I think there's still some questions around the validity of the milestones data that we're getting. So I think this is where we want to be eventually, but I think there's still questions about the quality of the data. And I think we're projecting validity onto this milestones data set that may not be perfectly true. So I don't think we can use it as an outcome quite yet. This is the type of data we get. This is national data for PM&R, and you can see across subcompetencies, it tracks nicely. There's central tendency that tracks nicely, and then there's outliers, which are interesting. This is what you see for every specialty and every subcompetency. So I don't know, it almost looks too good. Like, okay, but let's be skeptical and really dig down. And I think this is where qualitative and quantitative have to mix together, and we really have to do some interviews and find out what's happening with the CCCs and look at the assessment tools they're using and so on. And you can go into this whole validity argument that people love to go into, content validity, response process validity, predictive validity, et cetera. But the point here is that, yeah, not ready for prime time maybe to correlate UME milestones with GME milestones. I think we're getting there, not quite there, maybe a couple of years. But this idea of, does everyone agree what these competencies are and how to assess them? Subcompetency by subcompetency within a specialty, within a program. Do the program directors and the CCC chairs and the core faculties all agree that they're talking about the same thing and that they're all equally important? Go back to the neurosurgery example and think about that. I bet there's some variability. So these data patterns can reflect a number of different things. In other words, obviously we want them to reflect the resident's underlying ability, but they can reflect all kinds of other things. And one of the things that they obviously reflect is the poor assessment tools. And so what I want to do is just show you briefly how we can improve the assessment tools for core faculty, make them more usable, user-friendly, and therefore the faculty are more engaged in making these assessments in a more genuine way and more authentic, and they're not afraid to rate someone a 1 out of 5, and they're okay with that. Like, how do you do that? And then just better analytics for not just the core faculty, but so I think that second point will engage the core faculty more, in a more genuine way. That if we give them better tools, simpler tools, more obvious ways of doing this, they'll buy in because they want to. They really do, for the most part. So let's help them. Let's meet them halfway. But also for program directors, one of the things I get, I went to the orthopedic surgery program directors meeting, and I showed them all of their milestones data, and I said, but the one thing you have to remember is that, the reporting of milestones is a requirement, but you don't have to send us level 4 data for all your residents. Like, that's not a requirement. And so, I gave my whole talk, and then an orthopedic surgeon stood up at the end and says, so you're saying that milestones are not used for accreditation of our programs? Milestones data? And I said, yeah, that's what I just said. And she said, so why are we doing this? Why are we sending you milestones? I said, well, it's CQI, it's a bit long story. Do you want me to repeat my talk? It's tough, right? Because people want this to really mean something immediately, and it's tougher than that. So creating a shared mental model for people, I think, will engage them more, people at different levels. Sorry, this is for Canadian audience. This would be DIOs here. Is this meaningful work is really what we're trying to do. And this is what I was talking with Mark about at the break. It's not just about data. It's about interpretation of the data, making meaning of the data, and then making meaningful changes at the system level. So competence is like a biopsy. Assessment of competence is like a biopsy. You never have perfect knowledge of the underlying competence of an individual. You can only sample it at different points in time. And that's the question. How good is your sample, right? But you're stuck with this. you have a distribution of residents who we shall euphemistically call pre-competent, and they have observed a range of observed competence, and you have to deal with that. Like there's, you don't know for sure whether this guy out here is truly competent or they're just kind of, they've had a few good days and you've observed them under ideal conditions, or if this guy's really a star and they're just, not expressing themselves. This is real program director stuff. And then you have this other group of competent residents, the same problem. You have a wide distribution, you just don't know. And then at the end of your training, you have to make this decision, and you say, well, where's my cutoff point? And there's a sensitivity and specificity diagram that we all love, and you have to avoid the false positives because that has true implications for patient care. And that's what keeps us up at night. Okay? So milestones are not ready for prime time, I would say, but we're getting closer and closer. We need to continue to do the validity work. We need to continue to build better assessment tools, to correlate it with UME data, and, oh, by the way, clinical outcomes and practice data and performance in the clinical setting, which is a huge, that's a career of work, right? So, but let's do it. Here's one cool analytic tool that how much time do I have left now? I'm okay? Okay. Here's one cool analytic tool that we've just developed, and this is to help program directors. So this is like a positive predictive value model or a negative predictive value for diagnosis, right, or treatment, response to treatment. So we took one emergency medicine patient care subcompetency called wound management. We looked at those residents at the end of training who achieved level 4 or greater, and then we tracked them backwards. And we looked at the population of residents who did not achieve level 4. And there was 273 of them and 1,069 of them, and we tracked them backwards because we know now longitudinally what their data are all the way back to December 2013. And so the question is, when are these two curves different enough that this gives the program director some confidence that they need to have a conversation with this resident or identify ways of maybe giving them some more experience or more attention or more assessments, frankly. So this is a nice analytic tool. Program directors are just getting this now, so hopefully the response will be positive and we'll get some dialogue about this. This is what it looks like when you break down the data. These are all the passers. These are all the people who didn't. These are not all the data. These are all the potential paths to level 4 and higher. These are all the potential paths to below level 4. You can see this one was rated at level 5 6 months before, and then below level 4 at the end of training. That's very interesting. There's lots of really cool things going on there. But these are some analytic tools that I think program directors will find very interesting. And finally, I'll just close by talking about better assessment tools. And I want to emphasize, I've spent a little bit of time on this because I noticed in looking through the slides for the subsequent talks that people refer to this assessment tool, so I just want to show you how it was developed. And this is really to help core faculty. So this is your typical evaluation form. You hand this to your general surgeon, and you say, please fill out this form on all the residents coming through your service for the next few months. And they say, I'm supposed to do what? How would I know if he actually knows any of this stuff? Or, just call him a 2 because he's in second year. Does that sound familiar? Yeah. So this is a validity problem, right? This is what we need to combat. So the problem, I've called this, also reframe this as the excessive adverb problem. There's, many, common, some, significant, basic. These are things that are interpreted in different ways by different people. So it's a language thing. It's semantics. People have trouble getting a shared mental model when you give them ambiguous language. No surprise. So what we did in Ottawa, Wade Gofton is the surgeon here in the middle, who's a brilliant guy who, took time out of his busy clinical work to do a master's in education. And this is what he came up with, and this is what we call the Ottawa Surgical Competency Operating Room Evaluation. And we can apply it beyond surgery. This is not specific to surgery. In fact, we've done one for assessing a day of running a clinic. Now it was a surgical clinic, but you can think about this beyond surgery, okay? But this was for a surgical procedure, the way we developed it initially. And the idea was, just like most assessment tools, you break down what you're observing into meaningful categories. In this case, technical performance, visuospatial skills, efficiency, case preparation, et cetera. And then you have your typical 5-point scale at the other end. What's interesting about this and different is the behavioral anchors for those 5 points. So what we did was we went into the surgical lounge after a day of OR with no residents present, and we asked the surgeons to describe the residents that they were working with that day. So this is kind of an ethnographic, qualitative, ground-up study. And this is how they describe their residents. Well, I didn't need to be there with this guy, right? Or I had to prompt them from time to time. I had to do the whole case. There's your 5-point scale. This has meaning to the surgeons because they generated the language. It makes sense to them. Now this has been refined and tested, and obviously we did some other qualitative work. And now we've replicated it in general surgery and a few other specialties. And yeah, you can see it's published in Academic Medicine now, 2012. But it comes from this idea that Jim Crossley proposed a few years back called construct-aligned scales. And so we can do a better job in developing our assessment tools. But I just want to let you know that this came from a nice qualitative, grounded theory kind of approach. And it's not all about data. Not everything's about data. We can do some good qualitative research to lead to some good quality instruments. And in this particular case, it was about translating what happens here into milestones. And this is our team. Eric, Kenji's our wicked statistician who just keeps me up at night thinking about R and SAS. And that's our team. So thank you very much.